The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
When Darryl and I were discussing speakers, he suggested we needed a talk on this, or maybe I did, and then I looked at the title and I thought, wow, that's pretty dry. How am I going to keep the people interested, not falling asleep or just thinking, where's lunch? So I'm not sure I'm going to be able to do that, but I'll have a go. I changed the title. That's the first thing. And we're going to talk about quality telephones, sheep and llamas, and it'll all become clear, I hope. I'm not sure I've got it clear. This is more of a debate, a discussion with you. Please feel free to input. Don't throw anything. Okay, so I think what we're about here is providing quality to potentially deteriorating children, to hopefully pick them up earlier, to get ahead of the curve, to be proactive, to do something useful, to improve an outcome that the mum or the dad or the child or their sibling might care about. Pretty much that's where we are. So when we look at how we go about this, I'm interested in doing something useful rather than just doing something. And when we think about useful things, there's a hierarchy of useful things. And I used to be the lead for simulation training in our network. It was a great job. I really enjoyed it. But one of the things you see here right at the bottom of this effectiveness hierarchy of effectiveness is education training. That's not to say we don't do it. We still very much do it, and there's definitely a role for it. But there's other things that we do that are actually probably more important at a system level. And I just want to go through some of these things and apply them to what we do in New South Wales around between the flags or our rapid response system. So we've got mandatory calling. You're in the red zone, you call. And we make it a nice experience when you call. We don't shout at you. Someone said earlier that they shouted at Concord. We don't do that at Westmeath. So we have a chat and we come and have a look and we share our thoughts and we share your anxieties. So we deliberately make it a social interaction. We have EMR. It's not as fancy as Melbourne's, but you know, Sydney's working on it. And it automatically charts now and puts people in zones, gives them reminders. Three yellows make a red. You don't have to count anymore, it just tells you. And at the end of the day, it pops out an automated watch list so that you can use it in your handover. Who's had a rapid response, who might have another one. We've got standard charts, which again, age-appropriate, colour-coded. We've got a system. It's relatively simple. It's one thing you call. It's no adding up. And it's the same response you're going to get 24/7, which is a 3-tier response. And it all comes out, the rapid responses and the arrests involve ICU. So that's normal business every day. We have a standard way of talking about these things, and we bring it up regularly in all the ward-based and the hospital-based team talks, and we put safety pauses in where we just recap on where this stuff is at. So that's just normal business too. We have watcher lists, I've mentioned, and parent-activated rapid response, which hopefully, I agree with Fenella, we don't need to use, but it's there like a safety net just in case we're stuffing it up. And we've got statewide endorsed policies that our CE cares about, and we have people looking after that and a committee of people oversighting stuff. And we have our training to understand how all these elements fit together. So that's what we do. We try and make it patient-centred, and we understand the importance of a fresh set of eyes in a timely way and to involve the home team. So when we do that, we see this graph I think you may have seen yesterday, if some of you that saw Lynette's talk, our nurse practitioner, because our dose after implementation roughly here just kept increasing. This is the number of patients that we saw that remained on the ward, and you know, there's a lot of extra work, we thought, for people just remaining on the ward, but we'll talk a bit more about that. And then since about 2013, you see roughly the same remain on the ward, not increasing anymore. This bar here, the red bar, are the people admitted with high dependency needs into our ICU. And that's changed a little bit, but not much. In fact, it went down again there. So you could say that hasn't really changed very much. And these are the ones admitted down here for intensive care needs, and perhaps they've gone down a bit, right? Maybe that's the payoff, but it depends a little bit how we classify. But overall, the numbers coming to ICU really have not changed. We're leaving a lot of patients on the ward, so what's this all about? Does it matter Well, it might. We'll talk about that. But importantly here, look, this is an implementation phase. We introduced the charts, we had the systems in place, we said this is D-Day, off we go. But we didn't go off in a stepwise change like a seizure starting on arrhythmia. We kind of built, and saturated whatever system we've got. And now, that was our implementation phase as I look back, and now we've got a stable system, and this is our ongoing understanding of the situation we have. And when we look at these data, we've got to look at them separately and understand the context in that way. So it got me thinking a bit about data. We kind of show our data and we look at it quite a lot, because when we index it by the hospital activity per 1,000 hospital admissions, you see this idea of dose comes about, and our dose increased and now is relatively stable. And you can see, as I said earlier, the ICU admissions per 1,000 ward patients hasn't changed much. But what has changed is the ICU mortality of the patients that have come into the ICU, and it's pretty much halved. And see, back in 2009, before we had calling criteria in place, our dose there was actually higher than the following year, bizarrely. I think we started midway through 2010 and didn't really get going with improving dose till 2011. And then when we plotted the subsequent years, we noticed that there was pretty much a straight line going through this graph, which was the dose of rapid responses on the ward patients, most of whom stayed on the ward, and the ICU mortality on the ones that didn't stay on the ward. And we found that interesting. So we've got a dose-dependent response in terms of ICU mortality. So we like talking about ICU mortality as our outcome. Maybe that's justifiable, maybe not. Okay, well, let's have a think about this. I've spoken a bit about systems. Well, what about specifically our system? And you tell me, is it a rapid response system? I've been thinking about this and reading other people's papers and looking at the accepted wisdom, and there's plenty of it. I think we do have an identification limb. I think it probably does start to detect at-risk patients. We've got some tools around that and clear guidelines. We use family. We've got a response limb. It's quite standardized. We've got skilled people in it. We use watchers list, team talks. We've got good governance. There's a hospital service committee which is actively involved and bridges all elements of our system, and it's got CE support and executive support. And we, as I am proving to you right now, involve ourselves in QI activities around the deteriorating patients. So yes, I think we have. But it's a question worth asking yourself, because just having a MET team doesn't mean you have a rapid response system. I guess at this point it's time to come back to the title. So the telephone. In the 1920s there was a physicist, I think he was called Shewhart, who was asked by Bell Technologies to look to improve the quality of telephones that were being manufactured. And he thought he'd do this by... Well, at first he didn't really know how to do it. Then he came upon this idea of looking at the variation in the kinds of phones they were producing and how good they were. And to help guide this idea, he developed a simple graphical method of describing the variation. And I think still it's a very useful thing to consider. And it's called a control chart. And when some of you may be familiar with control charts, and many of you are familiar with QI methodology, and I don't mean to teach you how to suck eggs, but it's just worth considering that within all the hospitals in New South Wales or Australia or the world that adopt their own rapid response system, that they're not all the same. And they probably do cluster. And in this example, which is actually about GPs and their antibiotic prescribing habits, not all GPs are the same either. And when you look at them, initially you could draw this line through here if you use them all as a single group, but you can then start saying, well, these guys down here look like low prescribers compared to these guys, and we'll make separate control charts for them. Now we've identified two populations. And I think this kind of thinking is probably very relevant to rapid response systems. We're not all the same, some have different characteristics, and we should understand better how we might cluster and classify our rapid response systems and specific institutions. Now the point of doing this really was start to understand this idea that there's common cause variation, and by which Shewhart started to talk about, and people have gone on to talk about, the fact that within this group there would be no assignable cause, no obvious reason why they are a bit different. but between the groups, you start seeing assignable variation. And so when we look at this now in modern-day QI methodology, we've developed other ways of doing that. But why would we, and I'll come to that, but why would we get variation? Well, there's loads and loads of reasons. I've been hearing more and more and more, and the longer I sit in these meetings, the more I meet, the more complicated it gets. The granular complexity of our systems is huge, and we shouldn't expect to be able to compare that hospital with that hospital and easily understand that when we measure a simple outcome that we're going to get anywhere near the same kind of changes or effect sizes. So daytime, nighttime availability, are you track and triggering? What kind of criteria? Are they sensitive enough? What about those barriers to activation? Fenella's gone into a few around parental activation. Are you doing parental activation at all? What routine follow-up of calls or identification of high-risk patients do you have? What's a ward arrest anyway? And is it that you don't have any ICU beds at all, or do you have a different ratio of ICU, HDU beds in your institution compared to ward beds? I know for a fact the two hospitals in Sydney have a very different proportional ratio of ICU beds versus ward beds. And so that changes the level of illness you probably need to get to actually be admitted through the door. So when we're talking about ICU admission or unanticipated ICU admission, it's very difficult to really understand that. What's your dose? That's fundamentally important, it seems. What kind of end-of-life care measures? That's been mentioned before in the session that was given by the speaker from Concord. That was Stark when they opened the palliative care centre right down the road from where they were, and what changed in their outcomes. And what are your government and QI arrangements, and are you serious about it? So, what kind of sheep are you? And there might be more than one kind in the same paddock, and I think that's becoming more and more important to understand. I hope that wasn't Jonathan telling me on that. Okay, so back to the idea of control charts. See here, there's a normal distribution here that's being described in this chart. So we pick our outcome of interest, whatever we're going to choose to measure. And we start to plot it regularly over a period of time. And we see that it bumps around because there's variation. Now the variation here could be common cause variation. It just bumps around the mean variation. But then suddenly we're getting multiple dots heading the same way, and there's in QI methodology, you'd be aware that once you get to a certain number of dots all heading the same direction, or when you go beyond certain control limits, you start to talk about variation that isn't common cause variation, that you might be able to assign to something that's going on. And that might be a good or a bad thing that's going on. And in this way, we start to dig into our data a bit more. And I know many people are already using this, but if you're not, maybe we should be. But the million-dollar question is, what value are we observing? What is this outcome that we're all trying to achieve? I'm talking about paediatrics, I guess. But what outcome should we measure, or what questions should the outcome measure inform? So I don't mind what it is, but I do think we probably should agree. We haven't agreed yet. So I'm open at this point to suggestions. And in fact, tell me what you measure. What are you guys measuring? Loud. No one measuring anything. Of course you are. Tell me.
Well, mortality is obvious.
Where?
It's easy.
Hospital. Hospital mortality. Yeah, okay. Hospital mortality. Good.
Out of ICU mortality and in ICU mortality.
Okay. Can we divvy that up? Good. Anything else? Is that it? Cardiac arrest. Yeah. Where? Repeat calls. Admissions to ICU.
Admission to ICU post-med calls. Admission to ICU post-repeated med calls. Admission to ICU 24 hours after med call.
Okay. Any more?
We don't do anything. We measure.
Yeah, you collect data. It's good. Say again?
We measure interventions on the call.
Interventions during the Met call. Yeah. What do you do? Yeah. Anything else? How about Belgium? You're from Belgium. Yeah. Unexpected death. I knew there'd be something. Something. Yeah. Very good. Okay. Well, I think these are all valid suggestions, and we tend to measure a lot, but we don't report all of it, and we don't quite know where the money is in terms of the measurement. I think some of this was alluded to in other speakers. Does it reduce cardiac arrest rates, this rapid response system? Is it good for children? good in whichever way you wish to define that? Is it saving us money? We're all taxpayers. Does it improve efficiency of healthcare delivery? Like, can we do more of that thing in the same number of bed days? Do the staff think it's any good? Do they value it? Do families value it? Does it save lives? These are all valid questions, and some of the measurement outcomes that you've suggested there might speak to some of these things. But we don't even know what we really want to speak to. Perhaps we should form our question very carefully and then try and find the best outcome measures, try and avoid composite measures to actually get to that. So I'm talking as though there's no data in this field, and of course there is. And there's some superb work, particularly coming out of 2 or 3 units. In this study from Bonafide, they've talked here about unplanned transfers to intensive care, critical deterioration, mechanical ventilation within 12 hours after transfer to the ICU, and vasopressor infusion within 12 hours after transfer to the ICU. 12 hours seems a long time. You know, we can stuff it up quite badly in the first 4 hours and then need to use the vasopressors. But anyway, notwithstanding that, you can see here the intervention line. I don't know if it comes out that well. It does. These vertical lines in the middle of each graph is where their intervention starts. And they've plotted their likely trajectory and becomes a dotted line. Then they say this is what we actually got. Now, that's fine, and there are some significant things here. But what I just want to point out is that one's still going up. Okay, that one's the first one, unplanned transfers to intensive care. Whereas these ones are starting to go down. And this one's actually flat, okay? So really depending on what outcome we're looking at, we're going to see different things. And the outcome, therefore, becomes very important. And what you'll notice is there's huge variability before and there's huge variability afterwards. And understanding whether that's got some specific cause or is a common cause variability is probably really important when we're trying to unpick our data. And generally, and I'm talking for our rapid response system and how we look at the data, we're not as sophisticated as all that in analysing our data. As I've mentioned, we're really happy with ourselves because we've got a lower ICU mortality, and that's all we want to talk about. So what should we be talking about? What system performance measures should we use? Well, I think it's been described that we should measure outcomes that are meaningful to patients and their parents, and something the acid test is something the patient and the families care about. Do they care? You say you're going to measure it, they go, yeah, nice one, I like that, that's a good idea. I would care if that was going up or down. But at the same time, we do have to understand how our system is behaving. Remember that hierarchy of effectiveness and how we can affect the system. We need to understand afferent limbs and responding limbs. We have to understand the governance around the system. And so we do need process measures for sure. Because if you don't start your car up, it doesn't travel very fast, right? So just measuring the speed of your car is not enough. Okay, so we actually have to understand the thing is working and it's working at a reasonable lick. And we have to have balancing measures. We heard before that when we're out there looking at the patients on the ward, well, perhaps we're not looking at the ones in the ICU and we're delaying treatment and worsening outcomes possibly in those patients. And so we've heard about resourcing. We have to understand how to resource the teams and the other activities that are related. And so, yes, we need balancing measures. I'm not intending to tell you what any of these things are, but I will reflect on outcome measures a little bit more with you, because there's a little bit more out there in the literature. So you've mentioned a few things. Cardiac arrest outside ICU, but, you know, there aren't many of these MET calls that are arrest calls, or these rapid response calls that end up being arrest calls, or they shouldn't be. And not all code or arrest calls turn into an arrest event. And how do you define an arrest event in PEDS? A lot of them are respiratory arrests. They're not unimportant, but they're just not cardiac arrests. So if you use cardiac compressions or chest compressions as your yes-no, dichotomize the data that way, then that's not going to work. You get a very small number. Are the events, whatever you define them as, preventable? Well, depends who you ask. It's really hard to determine that post hoc. What about in hospital mortality? That's pretty clean cut, but yeah, that's quite rare actually, and there's lots of reasons why people die, and some of the time the intention is that they're coming in to die. And how do you define end-of-life care and how do we nominate people for that. That varies a lot. ICU mortality, my particular favourite because we're good at it. Obviously, there's prone to selection bias and multifactorial causality. They may stay in the ICU for 32 days. We can't just say it was because or not because of the rapid response call. ICU length of stay, well, that's not a bad thing, but again, we get exit block, and I'm sure many of you do too, and there's multifactorial causality there. So none of these things are perfect. So what about this? Critical deterioration. This has been proposed. Any patient transferred from the ward to ICU and receives vasopressors and is ventilated, including non-invasive, which we do more and more in peds, within the first 12 hours of ICU. But 12 hours of ICU, you know, it's a bit cool. What about this one? Unsafe transfers, unrecognised situation awareness failure events, unsafe. And that's a patient transferred from the ward to the ICU that receives vasopressors or has at least three fluid boluses within an hour. Now, I don't know how good you guys are, but I'm struggling to get 3 fluid boluses in my patient in the first hour because it just doesn't happen. And so even if I want to, I can't. It just will not happen. So I find that one a bit tricky. Perhaps an hour is too short. Trip events, any patients transferred from the ward to ICU ventilated, including NIV, or who receives vasopressors within the first 2 hours. Maybe, worth a look. The trouble with these ones, and they're good ideas, and there's some data around them, is that they vary in their specificity and sensitivity and the relationship they would have with the outcome for the patient that the mother or the father would care about, like do they live or die, do they stay a long time, lose a limb, that kind of thing. We haven't really begun to understand that relationship because we yet need to study these markers and see how useful they are in that regard. They need further validation. Of all of them, probably the best validated one's the first one in this list. So I'll stop there, but I just summarise by saying effective rapid response systems are meant to be comprehensive, hospital-wide, trying to reduce harm and mortality. Right? I think we'd all agree with that. There's got to be a framework. First we identify, then we respond. We put some governance and QI around that. And it's a given that it varies greatly in terms of design, implementation and function, in terms of dose, in terms of leadership, in terms of the ability to empower the staff, the parents, the families, and to do what we're setting out to do in the first place. And that variability has to be there because we may have llamas in a field for a reason and sheep in another field for another reason, and there are good reasons often to keep it that way. So we don't have to be the same. Variation exists. Some of it needs to be explained, some of it just needs to be there. But we have to understand it better, we have to measure it, and I think we should report similar stuff and utilise the QI methodology. Thanks very much for your time.